Hello, my name is Matthew Memoli. I'm the director of the Laboratory of Infectious Diseases Clinical Studies Unit in NIAID at the National Institutes of Health. Today I'm going to talk a little bit about a project that we've done over the course of the last year. This was a large-scale serosurvey to investigate the number of undiagnosed infections that existed early in the pandemic with the SARS-CoV-2 virus. I'm going to talk about the initial results from that study that are about to be published and talk about what they mean, how maybe we could think about those results, and then use that as a springboard to talk briefly about why we need to be thinking about broadly protective / universal beta coronavirus vaccines. So just a quick disclaimer, some of the things I'm going to offer are my opinions as a scientist. So when I talk about some of the interpretations of the results and some of the things that I'm taking away from them, I want to be clear those are not the official position of the U.S. government, the NIH, Dr. Collins, or Dr. Fauci. These are, again, as I said, opinions based on my experience with respiratory viruses as the director of a clinical studies unit in which that I've been doing studies of various aspects on respiratory viruses for the past 16 years. Also, I want to make clear that I have no financial interests or connections to any company or vaccine manufacturer. So the study that I'm going to talk about here for the majority of the time is what we call a trans-NIH effort. It included individuals from multiple institutes within the National Institutes of Health. My team, the Lab of Infectious Diseases, led this study. I was the PI of the study. But we had a lot of assistance from a lot of other people. These included resources, clinical resources, particularly sites that helped us do the study through the National Center for Advancing Translational Sciences. We had a lot of laboratory support from Dr. Sattler in the section for immunoengineering at the National Institute of Biomedical Imaging and Bioengineering, and a lot of support in terms of the production of the antigens that we used to do the tests from NCI Frederick in the National Cancer Institute, particularly Dominic Esposito. And it really took all four institutes together to get this study done. And so we're very proud of the fact that we did this as a large collaborative effort. So this study was a clinical protocol that we started last April. So shortly after the pandemic really began in the United States in March, we started this study in April. And the primary objective of the study was to estimate the number of people or the prevalence of antibodies in people that were undiagnosed with COVID or SARS-CoV-2 infection. So we wanted to really get an idea right away how many people have seen this virus, have been infected or been exposed, but didn't know it, essentially. And how do those numbers compare to the numbers of cases that were actually identified? And so as a primary outcome measure, we used an anti-SARS-CoV-2 spike and receptor binding domain ELISA assay. So we looked for antibodies against the spike in the RBD. Those antibodies included IgG, IgM, and IgA subtypes. We've now moved on to a phase 2 part of this study, which includes a follow-up, which I'll talk briefly about at the end. But what I'm going to talk to you today about, for the most part, is this phase 1 portion of the study and the results of that portion of the study. So how did we do this study? Well, we were under unusual circumstances for getting this study done. We wanted to rapidly recruit individuals, get blood from them, and test them, but do this in an environment in which we were under very strict social distancing rules. If you remember, at that time in the pandemic in April was when really everything was locking down. People were not going to work, no one was going to school, everything really was shutting down, and so this wasn't going to be easy. So we devised a method in which we could access people at home. And this gave us two benefits. One, we could stay socially distanced, but two, we could access the entire country and do this as a nationwide study. And this was really exciting to us because being able to do this on that big a scale was something no one was doing at the time. So my group in the LID, we led the recruitment and coordinated the study. We worked with multiple sites from the National Center for Advancement of Translational Sciences, and we had call centers set up in which we could call individuals who volunteered and then consent them by phone for the study, ask them the necessary questions, send them electronic questionnaires by email, and then send them a home sampling kit in the mail. And this was something that I discovered in searching around for a way to do this. There were these kits called the Metra home sampling kit made by a company called Neoterix, which you see down in the bottom right, which were able to collect 20 microliters of blood per tip from a simple finger stick. And we were able to get 80 microliters of blood from individuals who were willing to give us 4 of those tips from one finger stick. They could be mailed back to us safely in the mail, stored dried, eluted, and then used for testing antibodies. And it turned out that this worked really well. So this gave us the ability to collect blood from the entire country without ever having to interact with anybody or having to have them go and get their blood drawn. They were able to do this themselves at home. So this really made this study possible. And with the help of the University of Pittsburgh and University of Alabama, we were able to recruit the individuals we needed to do this study. In the laboratory, Dr. Sattler led the efforts to standardize ELISA testing for these samples. And so she tested both fresh blood and dried blood on the tips using the ELISA methods for both the spike and the RBD. She did a lot of work devising the optimal antigens to use, the constructs, and so on and so forth, and eventually came up with a very nice, sensitive, and specific ELISA for both the spike and the RBD. And we used a method in which we tested both IgG and IgM for both the spike and the RBD. And in order to be determined as a true positive, you had to have at least one spike and one RBD antibody positive. So either both IgGs, both IgMs, or a combination of one IgG and one IgM. And this gave us a really nice specificity. And working with our statisticians, we were able to devise the optimal cutoffs for these assays so that we were really getting a nice specific result and ideally not calling anyone who wasn't truly a positive, while at the same time not losing too many true positives as false negatives. And I should mention those methods were published previously in Nature Communications in mid-2020. So what happened with this Serosurvey that we did? So we actually were able to identify 462, almost 463,000 volunteers. So this was through advertising, press release. We had an email set up in which people responded, as well as phone calls, saying they were interested in participating in the study. So we were just amazed at how great a response we had and how many people were interested in participating in this study. Now, we didn't need that many people. That was way more than we could possibly test. But this gave us a really nice base to work with. And so what we did was, because we wanted to access the entire country and get a very representative sample, we sent all of those individuals a simple demographic screening question. So questions like, what's your race, what's your ethnicity, your age, your sex, where do you live, and so on and so forth. We had 241,000 people respond to that demographic survey. So now we had basic demographics on over 240,000 people. This allowed us then to use a custom computer program to do what's called daily quota sampling. So we had selection criteria based on the location where people lived, the age, the sex, the ethnicity, those factors that I was talking about. I'm going to show you those in a minute. And we said, you know, based on the US Census data, how many of these different types of people do we need from different parts of the country to have a representative sample? And so the computer, on a daily basis, would access this database of people and determine which people we needed to meet our quotas over the correct time frame that we were doing this, so that we would get a nice representative sample spread across the entire time frame that we were doing the study. And so this took any kind of subjectiveness to the patient selection out of the question and gets rid of that bias. It was completely objective and based on getting that representative sample. And this turned out that it worked really well. The computer would give us a list of people to call. The call centers would call those people, try to recruit them. Some would come, some would join the study, some wouldn't, and then the next day we'd get a new list of people to call, and we did that day after day until we reached the number of people that we needed in the study. So we invited over 27,000 people into the study. You can see in this slide, it shows you the different things that happened. Some people didn't want to do it, some people didn't respond. But we had over 11,000 people accept the invitation into the study. We ultimately enrolled 11,283 people. Those individuals now were all sent electronic questionnaires to gather more information about them, as well as a blood kit, as I showed you a few minutes ago, that micro sampling kit. And as you can see, again, different things happen when you do these kinds of studies. Ultimately, we had 9,089 people return their kits and samples, as well as surveys. And then when you analyze those data, of course, there's always sometimes some samples that don't work, some samples that aren't in good condition, people didn't fill out the questionnaires right, what have you. Ultimately, we ended up with 8,058 people, which we had a full data set on that we were able to use for the analysis. And this slide goes through a little bit more about how we did that, but those are basically the numbers. So ultimately, we had 8,058 people spread across the entire United States, and I'm going to show you how that looked right now. So the first thing we did once we had all this data was we wanted to look and determine how representative a sample do we have. Did our selection criteria work? And so we went ahead and compared our Serosurvey population, which you're seeing over on the right, to the US population based on census data. And what you see is that for our selection criteria, which are listed in this slide, things like the geography, where did someone live, their age, their sex, their race, their ethnicity, and whether they lived in an urban or rural area, we did extremely well. For example, 16.7% of the people in our study were from the Northeast, compared to 17.6% of people in the US Census, really close. Same goes for the other regions of the country, as you can see here. Age group, we did really well again, 42% between 18 and 45 compared to 46% in the US Census, 15% between 70 and 95 compared to 14% in the US Census. So again, very close numbers, so we're really happy with this. The same went for sex, as well as urban and rural, and then race and ethnicity. Now you will see some small discrepancies. For example, we're a little short on black participants, only 9.2% in our study compared to 12.9%, but we were still very close. And what we did do is, as we did the analysis, we did look at any of these discrepancies that were present in the data, and we weighted the results to make up for those discrepancies. So you can adjust for the small lack in black participants, or say the small lack in 18 to 45-year-olds, by adjusting the meaning of each individual in your study. And so we didn't have to do this very much for the selection criteria. However, we did have to do this a little bit more for the other criteria, the non-selection criteria that we also weighted our samples for. So obviously we couldn't use every single possible criteria for selection. We had to decide on what we were going to use, which you saw in the previous slide. But on this slide, what you're seeing are additional weighting criteria. So this was additional information that we collected on the individuals once they were in the study, that we then compared to the US Census and made adjustments for if necessary. And I'll give you some examples of why. So you can see we looked at how many people had children. That wasn't too far off from the general population. But when you look at education, for example, we had a far more highly educated group of individuals in our study than in the United States. 82% of our participants either graduated college or had more education than college, whereas only 28% of the United States falls into that category. So this was obviously a very large discrepancy, and we had to do significant weighting to adjust for that factor. Another good example here would be whether people had received a flu vaccine in the previous year. You can see that we actually had a much higher percentage of people who had received flu vaccine who participated in this study compared to the general population. So that was another thing that we had to significantly weight for. But as you look at all these numbers, you do see some discrepancies. Every single one of these, including the selection criteria and these criteria, were taken into account, and weighting was done as needed as part of the statistical analysis. And in our paper, this is all explained in detail in the appendix that will be included with that paper when it comes out in Science Translational Medicine, hopefully within the next few weeks. So going further into the results, we know we had a pretty good representative population. It was representative of the age, sex, race, ethnicity, and locations in the United States. So what did we actually find? Now, remember, what we were trying to do was we were trying to look for how many people were seropositive, meaning they had antibodies against SARS-CoV-2, but did not know that they had been infected or exposed. So they had never gone to a doctor, they had never had a test, they had never been diagnosed. I mean, maybe they had a test that was negative, but they had never been told, you have SARS-CoV-2 by any test or any doctor. And so when we look at this, and again, remember, this is between April and August of 2020. So right after the pandemic began, that first sort of 5 or 6 months we were looking at. And when we look at that, what we find is that the Northeast and the Mid-Atlantic had the highest rate of undiagnosed seropositivity. So you had 7.5% in the Northeast, 8.6% in the Mid-Atlantic. Those numbers are a bit smaller, 3% in South Central part of the United States, 1.6% in the Midwest, 4.5% in the Mountain and Southwest, and 1.9% on the West Coast. Now, interestingly, if you look at this, what you find is that if you think back to March, April, May, what you'll find is the greatest number of cases were in the Northeast and the Mid-Atlantic. And then as the pandemic progressed, you started to see it move into the southern part of the United States, then into that sort of, as well as the Pacific and the mountain. So what this is showing you is that initial snapshot before the virus really started to spread further throughout the country. So this is a very sort of early snapshot. And so these data made a lot of sense to us based on where the cases were, as it to some degree mirrored where the most cases of COVID were in the United States at that time. But as you can see, there were significant numbers of undiagnosed cases in the United States at this time. In fact, when you look at these numbers, ultimately what you get is that there were almost 5 cases of SARS-CoV-2 for every 1 diagnosed case by about mid-July. So if you take which is about the sort of slightly mid to later point of when we sort of hit the peak recruitment of our study, that July midpoint, around July 15th, we calculated it's 4.6, almost 5 cases for each individual case that was identified. So at that time, you had a certain number of cases, but you had much more significant numbers of undiagnosed cases going on at the same time that we didn't know about. And we'll talk more about that in a minute. Digging further into this data, we looked at all these different criteria that I talked about earlier and tried to determine, were any of these criteria more or less related with the chance of having an undiagnosed infection. So as you can see, people in the Northeast and the Mid-Atlantic were more likely, although not necessarily statistically significant because the confidence interval crosses that midline. That midline that you're seeing on this slide represents the sort of average, which was the average rate of estimate for undiagnosed infection. So to the right means it's more than average, and to the left, it's less than average. So you could see exactly what we saw on the map, that certain regions had more than average, certain regions had less than average. When you look at age, you see you had more in the younger age groups. The older age groups, you had less. Male and female, actually female was slightly higher. When you look at races, a lot of this has been discussed, I think. You see that really significant numbers in the black population. They were much more likely to have an undiagnosed infection than the general population, as were the multiple race. But really, the black population stands out the most here. Hispanic as well, a little bit higher, not as much as the black, but again, a little bit higher. And you could see urban more likely than rural. I mean, rural was way below average. So if you lived in a rural area, you were much less likely, at least at this time, between April and August, to have an undiagnosed infection. Now, some things I want to point out about this data that's interesting when you think about it. So if you look here, one of the reasons why you may have less undiagnosed infections, say in the 70-plus group than average, is because you are probably capturing more of the root of the cases. The reason is 70-year-olds who got COVID tended to do worse and seek medical care. So they were more likely to have a test and actually find out that they had COVID. Therefore, it makes sense that you would have less undiagnosed infections in a 70-year-old than, say, an 18 to 44-year-old who was more likely to just have maybe loss of a sense of smell or a little cough, but be fine. And so they might not even have bothered to go to the doctor or even realize they were sick. So in some ways, you can explain these numbers by that severity of disease that we saw in the differences in ages. And interestingly, if you start thinking about the races and ethnicities, because we have such a high level of undiagnosed infections in the black population, that may be more not necessarily related to the fact that they had a higher risk of COVID, but actually they were just more likely to either not go to the doctor, maybe they didn't have access to health care and weren't able to go to the doctor, or they just had less severe disease, and so you had a lot of people who just never needed to seek medical care. So in other words, the true case numbers that we have actually identified less than the true cases that are out there in the black population for whatever reason. And so it's likely that the mortality rate is actually much lower than the CDC estimate. So this is very interesting because when you look at these kind of data and then you go back and you look at the case data and the CDC data, it sort of changes how you need to think about those things. And I'll talk about that a little bit more here in a second. So we have lots of other factors, and I know this is hard to read. There's a whole list of different things we asked people about their lives to try to determine what was related to having undiagnosed COVID infection. I just summarized some points here. When we asked people if they had direct contact with patients, so in other words, healthcare workers, ambulance workers, anybody that would come into contact with a COVID patient on a regular basis, it actually didn't make a difference. They were right on the average. So healthcare workers fell right on the average. It made no difference to their risk of undiagnosed or diagnosed infection. It just didn't. Healthcare coverage, again, didn't change anything. So whether you had healthcare or not, didn't make a difference. There was the same chance of having an undiagnosed infection. Interestingly, people who had had a flu vaccine or pneumovax, the pneumonia vaccine, recently, they were statistically associated with lower seropositivity. Now, why that is, maybe it's behavioral. Maybe people who go out and seek those vaccines were more likely to, wash their hands, be more careful, not be around people who are sick. I don't know, but it's interesting. Also, people with diabetes were statistically associated with a lower seropositivity. Again, maybe behavioral. A lot of people with diabetes maybe are more careful about getting sick. Or maybe it has to do with sometimes diabetes can affect your immune system and you don't have as good an immune response, and maybe we couldn't detect antibody even after they had been exposed because their immune system wasn't responding as well. Again, I don't know the true answer. I'm just throwing out some possibilities here, and there may be others. Some other interesting things that were actually associated with a higher prevalence of seropositivity, so not surprising, anybody with a known COVID-19 exposure. So anybody who said, yes, one of my family members or somebody I knew, or I was, somewhere where I knew I was exposed, they were much more likely to have antibodies against SARS-CoV-2, so not surprising. Being unemployed, this was interesting. We asked people if they were working full-time, working from home, or they were unemployed, and actually being unemployed, you were more likely to be seropositive than in the other situations. An atypical living situation, so you don't own, you don't rent, either you're homeless, although we didn't really have a lot of homeless people in our study, but maybe you live with somebody or you live in some facility, different sort of more atypical living situations. Those individuals are more likely to be seropositive. Anyone with international travel, I think that's not surprising. What was a little surprising to me was people with HIV and kidney disease were more likely. Unclear why that is. Generally those types of individuals obviously would be around hospitals more frequently because either they take medications or they need to see doctors more frequently. So maybe that's why there was some exposure there. But I would have thought maybe they'd be a little bit more like the diabetes individuals who would be trying to be more careful. But, again, I can't explain all these results, but they're very interesting. And I think things that we need to continue to think about and do research on to try to better understand. So the things that I took away from all these data, well, one, as I mentioned, we estimated about 4.8 undiagnosed cases per identified case in the U.S. by mid-July of 2020. So that adds about 16.8 million cases to the 3 million that were diagnosed by July 15th. So now you're at about 20 million cases by July. The reported case fatality rate at that time was 4.4%. Right now, the last time I checked a few weeks ago, it was being reported at about 1.8%. But in reality, based on these numbers, the case fatality rate, at least in July, was probably 0.8% or less. In fact, I think it's likely that CFR is even lower, which really makes it similar to a novel influenza virus. I mean, a typical flu pandemic, say like the 2009 pandemic, you're talking about 0.1%, 0.05% case fatality rate. And I think we're approaching those numbers when we start taking into account the number of asymptomatic or undiagnosed infections where people didn't die and didn't get sick enough to seek treatment. We're starting to approach a novel flu virus type number. These data demonstrate how rapidly the virus spread, and that despite, what one would argue are fairly draconian public health measures, 10% of the adult population had been infected within 5 months. I mean, you take 20 million cases out of the adult population, that's 10% of the, 200 million adults in the United States. So, it makes you question, did the public health measures do what we said they were going to do? I don't know. Maybe things would have been worse if we didn't do it. But, I think we should think about that. And it's likely that we've had at least 60 to 100 million infections in the United States by now, 30 to 50% of the adult population, and it's possibly even more. I think these are conservative numbers that I have here. We also have to take into account that it's possible there are some individuals in the United States that may not be susceptible and may not mount an immune response. So there may be people who either have been infected and we don't know it because they don't mount a good immune response to the spike or the RBD, so we wouldn't be able to detect it. And there may be some people who can't even be infected by this virus for some genetic or other reason. So, what percent of the population is actually susceptible now? I don't know the answer to that question. The seropositivity in this study was seen higher in younger individuals, as we mentioned earlier. The case fatality rate in 18 to 44-year-olds, as of a few weeks ago, was being reported at 0.5%. Again, based on the data here, I think we're looking at less than 0.05%, which is a far lower number than the case fatality rate in influenza in young, healthy people. So should we be spending a lot of money and effort vaccinating younger people 18 to 44 now? Is it worth the cost and effort? I think it's a question that should be considered, especially because we don't know what it means for the future for those individuals when they're older. And I'll explain that in a minute. So why does this lead me to think we need a universal beta coronavirus vaccine? Well, RNA viruses change by nature. There's minimal to no error checking in these viruses. And so the evolution of these viruses, as they progress through a population, or even as they stay possibly in an animal host, you see variants or novel strains that can emerge. And this process is constantly occurring in nature. And when one of these viruses develops properties that allows it to start spreading rapidly through humans, no one can predict, but it clearly happens. We were warned of this, really, when you think about it, by the Sars outbreak and the MERS outbreak, both beta coronaviruses. In fact, SARS is 95% similar to SARS-CoV-2. Now, these didn't spread and cause a worldwide pandemic for various reasons, but they did cause, significant problems and concern in the areas where they began to spread. And so, we had an opportunity to look at those two outbreaks and say, gee, these beta coronaviruses can clearly cause a problem. Maybe we need to be thinking about what we're going to do if one of them truly becomes easily spread throughout the world. And I think had we spent the time and effort to finish the research that began when the SARS and MERS outbreaks started. There were vaccines that were being made, there was progress being made, but to some degree, when these things settle down and don't cause a pandemic, people lose interest, funders lose interest, and work doesn't get finished. Had we finished some of that work, we likely would have been in a lot better situation when SARS-CoV-2 emerged than we were. And so I personally feel we didn't heed those warnings, and I hope that we heed the warning of this pandemic so that we don't end up in a similar situation again in the future. All the current vaccines that we're using right now contain the spike protein in some form or another and are administered systemically in order to induce a systemic response to the spike protein. Now, this seems to be working and it's offering protection, but when we look into the future, and so I'm not talking about 6 months or a year from now, I'm talking 10, 20, 30, 40 years from now, these vaccines may offer very limited protection. If very large variants emerge or a completely novel beta coronavirus strain emerges that tries to cause another pandemic in the future, it's unlikely that a vaccine with this specific an antigen in it is going to offer significant protection. And so, I wonder if we're repeating history. In the early development of the influenza vaccines, all the focus went on specific vaccines against the hemagglutinin protein. Again, a surface protein that everyone could easily measure antibodies to, and so that's what was done. And what we've seen over time is that, yes, that vaccine is effective to some degree, but it has a lot of limitations. You have to keep updating it. You have to keep changing it. It's limited in how well it works in the elderly. It's limited in how well it works in immunocompromised people. It also doesn't offer complete protection. It offers certain protection in certain circumstances in certain ways. And what we're finding in influenza, and this is work that I've been doing over the past 10 years, is that there are other antigens, things like the neuraminidase, things like the internal genes that may offer T-cell immunity, that can offer other aspects of immune response that can be more broadly protective and in some cases even better correlates of protection. And so by focusing on the HA and manufacturing those vaccines, no one even bothered to think about those other antigens for many, many years until after the 2009 pandemic. And now we're finally starting to make progress in that direction. So I don't want to see us repeat that same history. We needed to make something quick, and that was done, and that's good. But now we need to start thinking, how can we broaden the protection? How can we make better vaccines? The other thing we need to keep in mind is that this is a mostly mucosal disease. These viruses infect through the mucosal membranes of the airways. And so in order to block that infection, systemic antibodies in the bloodstream is not your target. You really need to get immunity at the mucosal level, in the nose, in the throat, in the lungs, if you really want to block disease for these viruses. And so, thinking about how we can induce more mucosal immunity with vaccines, extraordinarily important for both universal broadly protective SARS-CoV-2 and influenza vaccines. Now, this question I've raised about vaccinating the young, one of the things I'm concerned about, and this is simply theoretical, it could be the complete opposite, is that if you vaccinate young people who have very little risk of death or hospitalization now with a very specific vaccine and block them from being exposed and developing immunity to the current virus, is it possible that by not allowing them to get the full protection from a virus like this, getting exposed to it so that you develop more T-cell immunity and other forms of immunity against other portions of the virus, could you be setting them up in a situation where 40 years, 50 years from now, when they're a high-risk group for such a pandemic, you could have another pandemic that they don't have any protection against, that if they had had more exposure to the virus now, they would have had more protection against when they're in their 60s, because they would have had some of this other immune memory. Now, I don't know the answer to this question. It could be completely the opposite of what I'm saying, but I think it's something we have to consider. And so if we consider that, if we can make a better vaccine, a more broadly protective vaccine, a vaccine that induces more types of immunity than just against that spike protein, that may solve this problem without having to have them exposed to virus. because you could give them a more broadly protective immunity that hopefully would offer them something when they are in their 60s and possibly exposed to another similar situation. So, I think these are things that as we, rush to vaccinate everyone, we really need to be thinking about. And so if we do approach these broadly protective vaccines, one thing I always say is that these broadly protective vaccines shouldn't just be broadly protective in terms of the viruses they cover. Obviously, we want them to try to prevent infection with any beta coronavirus. But it should also be broadly protective in that it protects as many different types of people as possible, as you're seeing in my slide here, right? Whether it's race, ethnicity, age, underlying illnesses, medications you take, we want to be able to protect as many of those different kinds of people as possible. And really to do that, you have to offer broad immunity of different types. Not everyone responds by developing systemic antibodies against a single antigen. Some people need T-cell immunity. Some people need develop antibodies against different antigens. We've seen this in flu. About 10% of the population does not make antibody against the hemagglutinin, but they have very good responses against the neuraminidase. What does that mean for vaccination for them? It's hard to say, but it's clear that people are different, their immune systems are different. We need to consider that as we move forward with these vaccines and as we think about our strategy for the future, because we don't want to end up in this situation again. So just to finish up, we are continuing this study that I described into a phase 2. This includes a 6 and 12-month follow-up of all of the people that were enrolled, so that over 8,000 people. They're all sending us or being offered the opportunity to send us a 6-month and a 12-month follow-up sample, as well as answering additional questions about how they've been doing, whether they've been sick, whether they've gotten COVID, whether they've had the vaccine. This will allow us to evaluate the evolution of the pandemic and the asymptomatic infections, what happened over time. So remember, I showed you that in the Northeast and the Mid-Atlantic, we have the highest numbers. Does that start to catch up in the rest of the country? Does the Mid-Atlantic and Northeast continue to increase beyond? We're going to find out as we do that. This will help us solidify some of the numbers that I talked about, some of these numbers that I'm saying could impact the true case fatality rates. We're going to find out how much did testing affect that. So for example, early in the pandemic, we're seeing almost 5 undiagnosed cases for every 1 diagnosed case. Well, we were doing less testing initially, so maybe as we did more testing, does that number go down? Or maybe it doesn't. Maybe it went up because there were more cases. We don't know. This continuation of the study will help us find out. We will be including testing in the next phase of the study that can determine whether someone has developed immunity from the vaccine or from a natural infection. So because of the way these vaccines are designed, we are able to look for certain antigens that aren't included in the vaccines that will help us determine whether someone has developed a natural infection versus a vaccine immunity. And so we'll be looking at that as we move forward. How many people have vaccine immunity alone? How many people have natural immunity alone? How many people might have vaccine plus natural immunity, either because they were infected after or before they got the vaccine? These are all questions we're going to be able to look at. And what does that mean? How high are their levels of immunity based on these different factors? Also, we're asking a lot of questions about how people responded to the vaccine. Did they have adverse reactions? What happened to them when they got it? This will allow us to correlate their vaccine responses as well as their natural immunity if they get exposed to sort of what happened with the vaccines. For example, do people who have adverse reactions, do they have stronger immunity after they get exposed to a virus, or stronger immunity after exposure to a vaccine, or does it not matter? So sort of questions that we can start to interrogate. And then, I hope this will help us gain further insight into how to prepare for the inevitable next pandemic. There will be another pandemic. Could be flu, could be a beta coronavirus, could be something new. But everything we learn about these pandemics can help us with the next one if we learn the lessons from them. And we tend to, for some reason, sometimes not learn those lessons. And so we need to really, really study this, look at how it correlates with previous flu pandemics, and think about what we can do to change our response in the future. And so, lots of people worked on this, and I have to thank all of them. And I'll just finish up and leave you with a quote from Thomas Aquinas. Thinking about we need to really think clearly and think logically, because the data is very complicated. What goes on in these pandemics sometimes can be very difficult to understand. And of course, with everything that goes on, people dying, people getting sick, it can sometimes be hard to keep our emotions in check. But if we're going to learn from this, we're going to have to do this and really try to understand what happened, what we've done, and how we can do better in the future. Thank you.